Okay. So hi, evening friends, evening everybody, bache, evening everybody. Let me see the link of the YouTube. Uh, will this link work on YouTube? Yes, I guess it's live now. Everything is working fine. So let's start. Guys, just give me a thumbs up or drop me a message if yes, now it's working fine. Perfect, perfect. So hi, evening friends, evening everybody, bache, evening everybody. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. I know degree. I always start my sessions with this because degrees पढ़ के अच्छा लगता है. I mean, it always feels nice when we have worked hard and our degrees are visible. So I guess it's working fine. Done. So let's start, and this is what we are aspiring for. That is, all of you are working extremely hard. I know it is not going to be easy. Sometimes, if a faculty, if he or she is slightly lazy like me, he'll slightly get late also. It's not going to be easy. Plus we'll sit for longer hours. I'll always give you time after coming back from clinics, especially in my pathology as well as microbiology sessions. You will always have time after coming back from the clinic to freshen up, to relax, to munch on something, and then to start studying, because I strongly believe that we can study with concentration only when we are comfortable in life. So whatever time we will be studying, we'll set few basic rules of the class in this session. Firstly, whatever time we will be studying, we'll do that with full concentration. Secondly, I am the laziest guy in class, so if I am making notes, I'll write everything for you. So if I am making notes, please write it with me. Keep separate registers, separate copies for all 19 subjects. Make your own handwritten notes. I know in DBMCI we are giving our printed notes and everything is available to you, but you have more than 1 year to go for the paper. There is no shortcut to success. Make your own handwritten notes. The recall will be much higher. Thirdly, suppose you miss out on writing something in the class, absolutely not to worry. You will be having all the notes, plus you have the topper notes on the app, and you will have all the content, everything with you. So primary objective should be understanding in the class. If we understand the concept well, the again our marking MCQs on that particular topic going right will be more certain. Fourthly, some of you will be my older students and stuff. I am saying it point blank, last 3-4 years, except the COVID part which I added, the all the content is the same, and I say it very proudly in the dental segment, because no new question has come in the previous 3-4 years from outside the content, both path and micro. So this means that if the same trend of the paper continues, everything continues the same, you are going to get exact questions from the content. So make notes well. This is gold standard. Lastly, participate more in the class. The first half of the session is on YouTube, and I guess then we'll be shifting to the app. So keep on writing it in the section, and I have my phone with me, absolutely not to worry. And when we shift to the app, we'll be talking either in the chat box or in Telegram as you feel comfortable. So perfect, perfect. This starts us with for our first one of the easiest topics in pathology, that is cell injury. So let us start with cell injury. देखो बच्चे, normally cell is in a state of homeostasis. Normally cell is in a state of homeostasis. It means it's able to do all its functions well. In case of an injurious stimulus, in case it gets an injurious stimulus, the cell tries to adapt itself. That is, it undergoes cellular adaptations. It tries to adapt itself. There are 4 main cellular adaptations, which are hypertrophy. There are 4 cellular adaptations, which are hypertrophy, Hyperplasia, hyperplasia, metaplasia, metaplasia, and atrophy, and atrophy. Normally, cell is in a state of homeostasis. In case of an injurious stimulus, it tries to adapt itself. That is, it undergoes cellular adaptations. There are four main cellular adaptations, which are hypertrophy, hyperplasia, metaplasia, and atrophy. If the cell is able to adapt itself, fair enough. Otherwise, it undergoes cell injury. Otherwise, it undergoes cell injury. Cell injury can be of two types, that is, reversible or irreversible cell injury. Irreversible cell injury occurs by two patterns, that is, necrosis and apoptosis. Irreversible cell injury. Irreversible cell injury, it occurs by two patterns, that is, necrosis and apoptosis. We'll do all of these terms one by one, starting with our first cellular adaptation. Let's start with cellular adaptations. Starting with our first cellular adaptation, that is hypertrophy. Let's start with hypertrophy. You tell me, rank 1 to 3, everybody gets one trophy only, but the size of the trophy is different. So hypertrophy, it is an increase in number of cells or size of cells. Keep on telling me the answers in the chat box. Hypertrophy, the size of the trophy was different, no? It is an increase in size of cells. Number nahi badh raha, it is an increase in size. So it is seen in dividing cells and non-dividing. It is a feature of non-dividing cells. Number was not increasing, na? So dividing nahi. It is a feature of non-dividing cells. So does it predispose to malignancy? For malignancy, for cancer to occur, the cells need to divide. This is seen in non-dividing cells. So this does not predispose to malignancy. This does not predispose to malignancy. Next point, examples. See, very commonsensical. The first 3 points, they were all the same, very commonsensical. When I always say this, whenever you study it as this is common sense, this has to be understood, this has to be remembered. It will go much faster that way. So hypertrophy, it was increase in size of cells. Non-dividing cells does not predispose to malignancy. Next point, examples. Now, before we go further, put a line on the side. We can divide the cells. Whenever we put a line on side, it means we are writing the miscellaneous points. We can divide the cells into 3 types, that is labile cells, stable cells, labile, stable, and permanent cells. Labile cells, they are continuously dividing in nature. They are continuously dividing. Stable cells, dividing and non-dividing. Stable cells, they divide under stress or injury. They divide under stress. So they are present in which phase of the cell cycle? G0, G1S, G2M. They are present in which phase? G0. They are in the G0 or the quiescent phase of the cell cycle. They are in G0 or the quiescent phase of cell cycle. Versus permanent cells, which are, the name tells you, permanent hai na? That is, they are non-dividing in nature. Permanent cells are non-dividing. So you tell me, what are the examples of permanent cells? Permanent cells, the examples being which muscle? You know there are 3 types of muscles, skeletal, smooth, and cardiac. Which muscles are permanent? Skeletal muscle. Examples of the same are skeletal muscle, cardiac muscle, skeletal muscle, cardiac muscle, and neurons. These are permanent cells, that is, they are non-dividing in nature. Skeletal muscle, cardiac muscle, neurons. Versus stable cells, they divide under stress. Examples being cells of kidney, liver, and pancreas. Cells of kidney, liver, and pancreas. That is why live organ transplant is done in cases of liver. Suppose my relative suffered from chronic liver disease I can donate up to 70% of my liver to him or her. Liver, hepatocytes are stable cells. They have unlimited replicative potential. They divide under stress or injury. So cells of kidney, liver and pancreas, these are stable. Versus labile cells, they are continuously dividing. Examples being bone marrow hematopoietic cells. Bone marrow hematopoietic cells, that is all the RBCs, WBCs, platelets, they continuously divide. All the epitheliums, name the epithelium. Stratified squamous epithelium. You know this from anatomy also. Stratified squamous epithelium present in skin, oral cavity, esophagus, cervix, vagina. It continuously divides. Stratified squamous epithelium. Columnar epithelium. Columnar epithelium of GIT. Cuboidal epithelium. Where is cuboidal epithelium present? In all the ducts, whether they are the ducts of lacrimal gland, salivary gland, breast, pancreas, all the ducts. Transitional epithelium. Transitional epithelium, which is present in kidney and urinary bladder. So all the epithelium, they divide. Hence, I had divided the cells into labile, stable and permanent. ठीक है, मान लिया. I fully agree. We are studying hypertrophy. My question to you is, everybody, I want you to write it in the chat box. I'll wait for your answer. Hypertrophy will be seen in labile, stable or permanent cells. 1, 2, 3. Hypertrophy. Hypertrophy will be a feature of non-dividing cells. That is the permanent cells. It is the permanent non-dividing cells which undergo hypertrophy. So, what are the examples of hypertrophy? Cardiac muscle, skeletal muscle. So let's see examples being cardiac adaptations. Examples of hypertrophy. Cardiac adaptations in hypertension. Skeletal muscle of bodybuilders. Cardiac adaptations in hypertension. Skeletal muscle of bodybuilders. All these undergo hypertrophy. Obvious tha na? Skeletal muscle, cardiac muscle, hypertrophy. Next, see, this was obvious. Chances of cardiac muscle or skeletal muscle being asked in your exam are minimal. What is asked is, put a star, gravid uterus, that is pregnant uterus, gravid uterus. Uterus in pregnancy, it is combined hypertrophy plus hyperplasia. Gravid uterus, it is combined hypertrophy plus hyperplasia. It shows both increase in number as well as size of cells. It is combined hypertrophy plus hyperplasia, but mainly it is an increase in size of cells, mainly hypertrophy. So pregnant uterus, it is combined both an increase in number and size, but mainly it is an increase in size of cells. And the last example is breast. Now, I know guys, we usually have a huge smile when we are talking about this, no double meanings, but we can divide the female cycle into puberty, pregnancy, lactation. In the first two phases, that is breast in puberty and pregnancy. In the first two phases, that is breast in puberty and pregnancy, it is combined hypertrophy plus hyperplasia. Both the number as well as size of cells increase. It is combined hypertrophy plus hyperplasia. Whereas by the third stage, that is breast in lactation, by the third stage, number has increased significantly. It is only an increase in size of cells. That is, it is hypertrophy only. Very, very important. So when we are doing the MCQs, or see, one thing is certain, when you are joining this course, you are not joining the course to increase your knowledge. For increasing the knowledge, college is there. I am being very blunt, I am being very, very frank. You are joining the institute, you are joining the course with one target, to get a government clinical seat. There is no other target. and I say it bluntly. After giving the paper, either the question is right or wrong, either we get our desired seat or not. There is no midpoint in it. So when we are doing the questions, this is one of the most high yield slides. Always put a star, make notes extremely well, always put a star on high yield points. This is asked. Gravid uterus and breast. Breast in puberty and pregnancy is combined, hypertrophy, hyperplasia. Breast in lactation is hypertrophy only. First class. This was our first cellular adaptation, hypertrophy. Next point. This gets us to the second cellular adaptation, that is hyperplasia. This gets us to hyperplasia. You very well know hyperplasia is an increase in number of cells. You know that. Hypertrophy was increase in size, this is an increase in number of cells. So dividing, non-dividing, it is seen in dividing cells, and of course predisposes to malignancy. Seen in dividing cells, and of course predisposes to malignancy. Hyperplasia. What are the examples of the same? I can divide hyperplasia into physiological versus pathological hyperplasia. It is of two types, physiological versus pathological. Physiological hyperplasia, again the cells in the bone marrow, they continuously divide. It is a feature of the increase in number. It's a feature of dividing cells. That is bone marrow hematopoietic cells. It's physiological hyperplasia. Next example is endometrium during normal cycle, endometrium during normal menstrual cycle. Again, you know this from physiology. Normal menstrual cycle, proliferative phase, secretory phase, and the menstrual phase. In the first two phases, proliferative and secretory phase, the number of cells increase. That is, it is physiological hyperplasia, increase in number. Next, hepatocytes. Remember, hepatocytes were which cells? Labile, stable, permanent. Hepatocytes, seriously Abhishek, thanks for the kind words, dear. I mean, no doubt it's these kind words which keep me motivated. I mean, seriously. Next, hepatocytes were stable cells. They were stable cells. That is why normally they are non-dividing, but they divide under stress. So they undergo physiological hyperplasia. That is hepatocyte regeneration. First class, this is physiological. Versus pathological hyperplasia. The classical example of which is atypical endometrial hyperplasia. Please note, this is atypical. This is not normal. Atypical endometrial hyperplasia, it is excessive, which predisposes to atypical endometrial hyperplasia. It predisposes to endometrial carcinoma. It is pathological in nature. So normal endometrial hyperplasia was physiological, of course. If it is excessive, pathological. Next, I need not even say this, BPH, benign prostatic hyperplasia. BPH, benign prostatic hyperplasia. You will be doing this extensively in surgery. Plus, as such, day-to-day activities, you know this, कि urethra passes through the center of the prostate. Now, if there is prostatic hyperplasia, urethra is compressed, leading to painful micturition, increased nocturnal frequency. There is incomplete emptying of bladder. The patient is having pain, elderly male, he is having pain. So he is not able to empty the bladder completely. Incomplete emptying of bladder, leading to increased risk of infections. You can be given a clinical history of an elderly male with painful micturition, increased nocturnal frequency, and increased risk of infections. Which cellular adaptation is seen? That is hyperplasia. It is an example of hyperplasia. This is one of the favorite questions of the examiner again. Hyperplasia. Next, this gets us to our next cellular adaptation, that is metaplasia. This gets us to the next cellular adaptation, that is metaplasia. Metaplasia means one lining being replaced by another. Metaplasia means one lining being replaced by another. देखो श्रेया, मतलब आई हैव नो आइडिया कि सृष्टि मैम कितने जोक्स और कितने नॉनवेज जोक्स मारती हैं, बट आई डोंट नो एनी नॉनवेज जोक. आई थिंक इन अ स्ट्रेट सिंपल लाइन लाइक दिस मेटाप्लेसिया, that is one lining being replaced by another. So what is the classical example of metaplasia? What is the classical example? Barrett's esophagus. I am sure all of us know this. Barrett's esophagus, in which the normal stratified squamous lining, of lower one third of esophagus, normal stratified squamous of lower one third of esophagus is replaced by columnar plus goblet cells. It is replaced by columnar plus goblet cells. That is Barrett's esophagus. I'm sure all of you know this. What is the normal lining of esophagus? Stratified squamous. Normal stratified squamous is replaced by columnar plus goblet. So you tell me, Barrett's esophagus is which metaplasia? Think before you answer. Squamous metaplasia, intestinal metaplasia, columnar metaplasia, या cuboidal metaplasia? Think before you answer. Barrett's esophagus. A very common mistake we do is we say it as columnar metaplasia, but nahi bache. Along with columnar, goblet cells are also coming now. So Barrett's esophagus is an example of intestinal metaplasia. Please put a star. Along with columnar, we have intestinal cells, goblet cells also, making it as a case of intestinal metaplasia. The word before metaplasia के पहले कौन सा word है? ज़मान नहीं बच्चे, columnar नहीं. That's what I wanted. It's one of the most common mistakes, those. Intestinal metaplasia. The word before metaplasia is the end lining. So normal stratified squamous being replaced by columnar plus goblet. Why? Main risk factor of Barrett's esophagus being GRD, gastroesophageal reflux disease, GRD. See, what happened was there is a reflux. So there is heartburn, there is pain. So the normal stratified squamous lining is converted to columnar plus goblet. Mucus will be secreted, so pain will be less. It is a adaptation. Main risk factor GRD. Reversible, irreversible? It is irreversible. Metaplasia is usually reversible, except Barrett's, which is irreversible. It is a cellular adaptation. So is it good or is it bad for the patient? Which it is bad. It is bad. Why? Because it is pre-malignant. Pre-malignant means it can progress to cancer. Which cancer? It is pre-malignant for, khud socho, think of it yourself, it is showing the presence of columnar cells, meaning glands will form. It is pre-malignant for adenocarcinoma. It is pre-malignant for adenocarcinoma esophagus. Esophagus has two main cancers now. Squamous cell carcinoma and adenocarcinoma. It is pre-malignant for adenocarcinoma esophagus. This is Barrett's. So before we go further, let us have a look at our first microscopic image. Acha, one more thing, microscopic images are asked, you need to know them. Initially everything will appear pink and blue, but gradually our eyes will get used to it. Why is it pink and blue? What is the stain used? HND, that is hematoxylin. Stain used HND, that is hematoxylin and eosin stain. Hematoxylin is blue in color and it stains the nucleus. That is why in any histopath slide, nucleus is blue, cytoplasm is pink, EO, it is pink and it stains cytoplasm. Nucleus is blue, cytoplasm is pink. So what we see in this slide is, देखो बच्चे, this is the normal stratified squamous lining. This is the normal stratified squamous, which is getting converted to columnar. It is getting converted to columnar plus goblet cells. Getting converted to columnar plus goblet cells, making this as intestinal metaplasia, that is Barrett's esophagus. This is what it looks like. Have a look. The normal stratified squamous being converted to columnar plus goblet cells, that is Barrett's esophagus. Grossly, this is what it looks like. You very well know that this is Barrett's esophagus. Grossly, it has a velvety red mucosa. Grossly, it is velvety red. It has velvety red mucosa. Now girls, you know velvety red very well, but for the guys it has a smooth red texture to it. It is velvety red mucosa, Barrett's esophagus. So coming back to metaplasia. Metaplasia was one lining being replaced by another. Asha, tell me this also. Is the mature stratified squamous getting converted to columnar? Or the stem cells which were forming squamous are now forming columnar? It is reprogramming of stem cells. The stem cells which were earlier forming squamous are now forming columnar plus goblet. So pathogenesis of metaplasia. This occurs, this is again asked, please put a star, but this occurs because of reprogramming. This occurs because of reprogramming of stem cells. That is metaplasia. So I can safely divide metaplasia. I can divide metaplasia into two types. I can divide it into two types. That is epithelial metaplasia. I can divide metaplasia into epithelial versus connective tissue metaplasia. I can divide it into epithelial versus connective tissue. Which is more common? Obviously epithelial metaplasia. Epithelial metaplasia is further of two types. Totally agreed. Someone totally agreed those. Epithelial metaplasia, it is again of two types. Make this flowchart comfortably. We will not write much below connective tissue, so not to worry. Make this comfortably. Epithelial metaplasia can either be squamous metaplasia, or intestinal metaplasia. It can be squamous or intestinal metaplasia. Which is more common? Squamous metaplasia. More common, squamous. So we have started with metaplasia. We can divide it into epithelial versus connective tissue. Epithelial metaplasia is again of two types, squamous and intestinal. Squamous metaplasia means normal lining is being replaced by squamous. Most common site being respiratory tract. Most common site of squamous metaplasia being respiratory tract. What is the normal lining of the respiratory tract? You know this. What is the normal lining of respiratory tract? Pseudostratified ciliated columnar. Where the normal pseudostratified ciliated columnar is changing to squamous. Why? Risk factors being smoking, main risk factor being smoking, or vitamin A deficiency. Very obvious. Most common site of squamous metaplasia is respiratory tract, where the normal pseudostratified ciliated columnar is changing to squamous because of smoking. ठीक है, मान लिया. Next point. Next example of squamous metaplasia is endocervix, where the normal columnar lining, where the normal columnar changes to squamous. Why? Main risk factor being infections by HPV. Very, very important. We will be covering HPV in detail in microbiology. But the Indian government has announced free vaccination for HPV in the younger female age group. So HPV, and for the students who are giving the paper this time in March, that is 2024, you are going to have a question 100% on HPV. For the 2025 batch, HPV again is a very, very important topic. Acha, which I'm not going to say actress, which famous personality died of cervical cancer? Young female famous personality died of cervical cancer recently. I'm waiting for this. I mean, come on. I'm sure all the guys we know. Girls का मुझे नहीं पता whether you follow it or not, but Poonam Pandey. So when her death was announced, tell me frankly, I mean, what was your response? Did you feel sort of low for her? She is from a very middle class or a very low background and has risen through fame and earned. So did you feel low? Yes, I mean personally, yes, I felt slightly bad about her, but then agreed, Twinkle agreed, but then we came to know after I think 1 or 2 days that it was just a awareness program by her. So after knowing that she is actually alive, did you still have sympathy or anger? I mean, but HPV पढ़ लिया है ओरल पैथ में, अरे वाह, ऑसम. देखो, ओरल पैथ अगर मान लो HPV पे क्वेश्चन तो आना ही है. अगर ओरल पैथ में पूरा कंप्लीट नहीं पढ़ा हुआ होगा तो आई विल फील गिल्टी. सो हम लोग अच्छे से डिटेल में पढ़ेंगे श्रेया, एब्सोल्युटली कोई डाउट नहीं है. नेक्स्ट, सो एक्चुअली दैट पूनम पांडे एपिसोड टॉट अस कि निंदा तो उन्हीं की होती है जो लोग जिंदा होते हैं. आई मीन दिस आई हर्ड दिस स्टेटमेंट इन अ टीवी सीरीज ऑल्सो, बट this actually is the gist ki if people are criticizing you or whatsoever, and we face it daily in day-to-day life. I'm sure many of you who are doing internship will be getting harassed by seniors, or you will be facing some toxic environment in the department. Don't worry about anything. In the end, it does not matter. Be focused in your goals, because it is your goals, achieving those goals, that is going to give you happiness in the end. It was a great carry home message by this PP episode. I know I should not say PP Poonam Pandey, but anyways, coming back. So endocervix, the normal columnar lining being replaced by squamous. So tell me the high risk HPV. मुझे दो बहुत famous high risk HPV के number बता दो. High risk HPV, they are 16 and 18. 6-11 low risk, 16-18 high risk. Next, the next example of squamous metaplasia, next example are the ducts, that is ducts of lacrimal and the salivary glands. All the ducts of lacrimal and salivary glands, breast and pancreas, all the ducts. The normal lining of the ducts is cuboidal. The normal cuboidal changes to squamous mainly due to the presence of stones. This is squamous metaplasia. Normal lining being replaced by squamous. Versus intestinal metaplasia, you very well know Barrett's esophagus. the normal stratified squamous lining of the lower one third being replaced by columnar plus goblet cells. That is intestinal metaplasia. First class. So we divided metaplasia into epithelial and connective tissue. The classical example of connective tissue metaplasia is myositis ossificans. The name tells you everything. Ossificans, that is bone formation in muscle because of trauma. Because of trauma. This is the master table of metaplasia. Everybody, please give me a thumbs up or like the video or give me a heart or anything if you are comfortable with all the points that we have covered till now. Everybody, because beach mein I'll keep on asking you this throughout the session because that keeps on reassuring me. I cannot see your face, that's the bias part, but I'll keep on asking you this so that I know that everything is going on track. So this is metaplasia. And lastly, this gets us to our next cellular adaptation. Asha, you tell me this. What is the parent organ? What is the parent organ in this? Of course, it's the brain. Brain mein, what we see normally, this is normal. What we are able to see are gyri. The elevations are the gyri. The depressions are the sulci. In the second image, it is associated with narrowing of gyri. Gyri patle ho gaye, narrowing of gyri with widening of sulci. The sulci, the depressions have gotten widened out. Widening of sulci. This is making it as a case of cerebral atrophy. So most common cause of dementia in elderly, Alzheimer's disease, making this as a case of cerebral atrophy. Our fourth cell adaptation, atrophy. So this starts us with our next cellular adaptation, that is atrophy. So there are four cellular adaptations: hypertrophy, hyperplasia, metaplasia, and atrophy. Atrophy, I need not even say now, is reduction in number and size of cells. It is a reduction in number and size. Very obvious. Now point is, I can divide atrophy into two types. That is physiological. I can divide atrophy into physiological versus pathological atrophy. What is the classical example of physiological atrophy? All of us have undergone that during embryogenesis. The classical example of physiological atrophy is during embryogenesis. Many structures form and involute during embryogenesis, like thyroglossal duct, and notochord. When we were embryos, we had a tail. Unfortunately, now we don't. It has undergone physiological atrophy, thyroglossal duct and notochord. Thymus at puberty. Next example of physiological atrophy is thymus at puberty. Next, guys, breast and uterus post-menopause. Someone agreed those. Thymus at puberty, breast and uterus post-menopause. Perfect. These are all physiological. I am again saying this. Whenever a question comes on this, you will not get confused in this at all. Obviously, this is physiological. During embryogenesis, thymus at puberty, breast and uterus post-menopause, obviously they are physiological. Point to be seen is pathological atrophy, the first example of which is senile atrophy. Pathological, the first example of which is senile atrophy, associated with aging. This is a common mistake. We think कि aging है तो physiological होगी. नहीं बच्चे. We have just seen that Alzheimer's disease is pathological in nature. It is not physiological. Next example of pathological atrophy is disuse atrophy. What did we not use that it atrophied? I mean, no double meanings. What did we not use? Skeletal muscle. Disuse atrophy of skeletal muscle. Of skeletal muscle because of chronic immobilization. Because of chronic immobilization. The patient is chronically immobilized. He's in ICU or he has undergone paralysis. That is why we ask a physiotherapist to move the limbs to prevent disuse atrophy. So pathological atrophy are senile atrophy, disuse atrophy. Next, denervation atrophy. The nerve supply has been cut. Denervation atrophy. The nerve supply has been cut. Why? Either because of surgery or trauma. Denervation atrophy. Atrophy occurring due to protein energy malnutrition. Fractures. See, all this, whenever will come in MCQs, will not go wrong. Main point was senile atrophy is pathological. And lastly, the last example of pathological atrophy is pressure atrophy. The last example is pressure atrophy. Pressure atrophy. किसने pressure डाला? Tumor ने. You know that tumors are of two types, benign, malignant. Benign tumors, they are well encapsulated. They grow locally. They do not infiltrate, do not metastasize. Versus malignancies, they are non-encapsulated, they infiltrate and metastasize. So कौन से ट्यूमर ने प्रेशर डाला? Which tumor? Benign या malignant? Benign tumor. Pressure atrophy. Benign tumor, but it was well encapsulated. It is growing and expanding locally. Benign tumor compressing nerve and blood supply. Compressing nerve or the blood supply of affected organ. That is pressure atrophy. Tumor, Niyati, agreed here. Agreed, it can be either a tumor or a cyst. Perfectly agreed. So, these are the cellular adaptations. Hypertrophy, hyperplasia, metaplasia, and atrophy. These are the 4 cellular adaptations. If the cell is able to adapt itself, fair enough. Otherwise, it undergoes cell injury. So this starts us with our next topic, that is reversible cell injury. Let us have a look at basics of reversible and irreversible cell injury, and then we'll take our first break. Asha, before I go further, everybody, please tell me this. What time do you approximately come back from clinics? I mean, I know I love to chat. I chat a lot in my classes, but that is what keeps your as well as I think my interest also in the session. So what I'm trying to ask is, I guess majority of you are back maximum by 5:20, 5:30 to home. So always at least before my sessions, bache, please munch on something. We'll start our session around 6:10, 6:15, I mean Indian Standard Time, and nobody ever will miss out even on a single minute of the session, because I will always drop a message on Telegram before starting. So absolutely do not worry. I'll always drop a message, and when we'll study, we will take our first break around 7:45 or 8 o'clock, depending upon how the topic is going, and then we'll wrap up around 9:30, 9:40. That will be the game plan always. That will keep the sessions, I mean, we divide the sessions into 2 equal parts, which will cover more content, at least the initial 2-3 days, because we are energetic in the first 2-3 days. By day 4, our energy will be slightly low. Acha, one very important thing. At the end of the session, end of day 4, we will be discussing previous year questions. So I want all of you, whatever we have studied on any particular day, when we start the next session, I will always start with the MCQs of this. So always revise. It will just take hardly 10-15 minutes for you to flip through the notes. Come prepared for MCQs before, like we have our next session tomorrow. I'll start with 5, 6 or 10 MCQs and then we start the theory part. End of day 4, we will do previous year questions, the previous 3-4 year questions. That will completely wrap up your pathology. We'll follow the same in microbiology also. So your subject wise test will probably be after a week or something, after the subject is over. But ideally speaking, you would have covered the whole subject and the MCQs with me in the class only, provided you revise whatever we do on that day before coming to the next class. And it's a humble request, please attend classes live. I know you will be getting the recorded format, you will have everything with you, but try to attend the sessions live, no doubt, no doubt. Next point. So let's come back, which is this starts us with reversible cell injury. We have seen the cell adaptations. If the cell is not able to adapt itself, it undergoes cell injury. Cell injury was of two types, reversible, irreversible. Acha, tell me this, which is the most common cause of cell injury? Most common cause of cell injury. Cell injury can be because of either ischemia, chemical injury, mechanical stress, mechanical trauma, radiation injury, infections. There can be multiple causes, but the most common cause of cell injury is ischemia, that is reduced blood supply. Most common cause is ischemia, which in turn leads to hypoxia, that is reduced oxygen. Actually, I'm very curious, which is worse, ischemia or hypoxia? Ischemia is worse because blood supply is reducing now. Along with reduced blood supply, nutrients will also reduce, versus hypoxia is just reduced oxygen. Next point, which is the first organelle? Nahi, kuch bhi. Come back, Shreya, come back. Most common cause of cell injury can never be heartbreak. I mean, I strongly will be talking about heartbreaks not in the first session, and at least not on YouTube. See, this usually happens. I know I should not be saying this, but before I start any dental class, the management always says to me, ki, Dr. Sushant, please be on time. Do not say rapid wrong stuff in classes. We'll stick to the session. Next point. First organelle affected in cell injury. You tell me, which is the first organelle affected in cell injury? Mitochondria. First organelle affected, mitochondria. Next point, which is the first biochemical feature of cell injury? First biochemical feature of cell injury. What is the job of mitochondria? It is the powerhouse of the cell. It synthesizes ATP. So the first biochemical feature of cell injury being reduced ATP, which reduces within seconds. And Shreya, Zaman beat dega tumko, because I guess Zaman always, I know today we are gossiping less because it's our first day of the session. By day 2 or day 3 we'll be friends. But coming back, first biochemical feature, reduced ATP, which is occurring within seconds. What is the main job of ATP? Asha, we cannot interchange these answers. First organelle affected, mitochondria. First biochemical feature, reduced ATP. ATP is needed for all the functions of the body, but it is also needed for maintaining sodium potassium ATPase pump. Where is sodium more? Extracellularly. Where is potassium more? Intracellularly. This imbalance is maintained by sodium potassium ATPase. Reduced ATP leads to reduced activity of sodium potassium ATPase pump. In turn leading to influx of sodium and water and efflux of potassium. Obviously, sodium was more outside because this imbalance was maintained by sodium potassium ATPase. So I can safely say that the first microscopic feature I can safely say that the first microscopic feature of cell injury is influx of water, that is cellular swelling. Very, very obvious. Nothing is to be rectified in this. All these are the first mistakes now. Guys, what do we always say? Ki, baby, sorry, this was the first time it has happened. Forgive and forget. Next time we will not do. So these are the first mistakes. So they are of course all reversible. They are reversible. Next point. In cell injury, what happens to cytoplasmic calcium? It also increases. Increased cytosolic calcium, which in turn leads to activation of numerous enzymes. Increased calcium, which in turn leads to activation of enzymes like ATPases, endonucleases, activation of enzymes like ATPases, endonucleases, DNases, and phospholipases, activation of various enzymes. ATPases reduce ATP. Endonucleases and DNases cause DNA damage versus phospholipases which cause membrane damage. कुछ भी नहीं था. देखो बच्चे, pure time pass. When a question is asked, I'll come back to this page, but see the question. When question will be asked, these are the 4 points. First, organelle mitochondria. First, biochemical feature, reduced ATP. First, microscopic feature, cellular swelling. What happens to cytoplasmic calcium? It increases, leading to activation of enzymes. This point was obvious. Which enzymes are getting activated? ATPases will reduce ATP. Endonucleases and DNases will cause DNA damage. Phospholipases will cause membrane damage. This point was obvious. So, if I have to write the microscopic features of reversible cell injury, I want you to tell me this. Let us start with what is asked, the next 2-3 slides. Microscopy. If I have to write the microscopic features of reversible cell injury, I can safely say that the first feature microscopically is, I want everybody to type it, influx of water, which leads to cellular swelling. Influx of water, which leads to cellular swelling. Next, now think of it yourself. If this is the plasma membrane of the cell with presence of microvilli, there is influx of water, there is cellular swelling. So it leads to formation of a bleb, that is blebbing. It causes blebbing, blunting, and loss of microvilli. Blebbing, blunting, and loss of microvilli. Cytoplasm ऊपर की तरफ फुट गया. There was influx of water, there was cellular swelling. So it led to a cytoplasmic bleb formation, blebbing, blunting, and loss of microvilli. It is also associated with dissociation of ribosomes. And swelling of endoplasmic reticulum. Dissociation of ribosomes and swelling of endoplasmic reticulum. All these points are the same. They are occurring because of influx of water. These are the same points occurring due to influx of water. Point to be noted here is, it is also associated with accumulation of small amorphous densities. Accumulation of small amorphous densities in mitochondria. Accumulation of small amorphous densities in mitochondria. Which is the main word in this line? Small. If the amorphous density is small, it is reversible cell injury. But if the amorphous density is large, it is irreversible cell injury. Very, very important and repeatedly asked. Small है तो reversible, large है तो irreversible. Suppose small or large, it is not written. So what will you mark? Nothing is written. In that case, amorphous density can be large also, no? So we'll mark irreversible cell injury. So small is reversible, large or nothing is written, irreversible cell injury. Next point. So this gets us to the microscopy of irreversible cell injury. This gets us to the microscopy of irreversible cell injury. I'll give you a very small 1 minute break, not a snacks break type, but a very small 1 minute break after we finish off the microscopy of irreversible cell injury. Not to worry, I know taking online classes is never easy. Watching continuously on phone is stress part, there's no doubt about it. So, but not to worry, we will be we'll be doing the whole class in multiple small sessions. Irreversible cell injury, you know this now, you tell me, which is the first feature of irreversible cell injury? Which organelle will get damaged? Mitochondria. What will be the first feature? You write it in the chat box. What will be the first feature of irreversible cell injury? Mitochondria will be visualized by electron microscopy, which shows accumulation of reduced ATP. nahi bache, reduced ATP was reversible. It shows accumulation of large. Even if I don't write large, it's perfectly okay. Accumulation of amorphous flocculent densities. Accumulation of amorphous flocculent densities in mitochondria. This is the first feature. Small was reversible, large or nothing is irreversible. Next point. Irreversible cell injury, it is also associated with nuclear changes. Which are the nuclear changes? That is pycnosis, nucleus condensed, chromatin condensation, pycnosis. Then it fragmented, that is karyorrhexis, and dissolved, that is karyolysis. Pycnosis, which is chromatin condensation, nucleus condensed, chromatin condensation, nucleus condensed, chromatin condensed. Pycnosis, fragmented, that is fragmentation of the nucleus, and dissolved, that is dissolution of nuclear changes. Once the nucleus is gone, it is irreversible, that is pycnosis, karyorrhexis and karyolysis. So again, I want you to answer, bache, what will happen to basophilia in the cell? What was blue? Nucleus is blue, cytoplasm is pink. Nucleus condensed, fragmented and dissolved. So basophilia, nucleus to dissolved na, basophilia reduces, eosinophilia increases. This is irreversible cell injury. Very, very important. Extremely important. Please have a good look at this slide. So what we have seen is microscopy of reversible and irreversible cell injury. We'll do a quick recap. Normally, cell is in a state of homeostasis. In case of injurious stimulus, it tries to adapt itself. It undergoes cell adaptations. There were 4 adaptations: hypertrophy, hyperplasia, metaplasia, and atrophy. If the cell is able to adapt itself, fair enough. Otherwise, it undergoes cell injury. Cell injury was of 2 types: reversible and irreversible. We have seen the microscopic features. Irreversible cell injury occurs by 2 patterns, that is necrosis and apoptosis. irreversible cell injury, which it occurs by two patterns, necrosis and apoptosis. Very, very important topic. Before we take our first, say, 10-15 minute break, I want to finish off necrosis. So everybody, firstly, please give me a thumbs up. Everybody, or like the video if you are comfortable with all the points till now. Secondly, let's have a very small 2-minute break at this point. Splash your face with water, put the phone on the side, keep the YouTube on. I mean, don't go to Insta or Snapchat or whatever. Keep your YouTube session on, and we'll be starting in 1-2 minutes. Just take a round around the bed and then we start in 2 minutes. Same on YouTube, no change in link, nothing doing. And we start with necrosis versus apoptosis. Done, bache. See you in 2 minutes. Okay, so guys, come back. Let's start where we had left off. There was a slight issue coming with my food. I mean, I had ordered, it was not coming. But anyways, let's start where we had left off. I guess everybody is feeling again comfortable and fresh. Now, what we have seen is irreversible cell injury occurs by two patterns: necrosis and apoptosis. Let us start with this very important topic: necrosis versus apoptosis. Let us start with the same. What is the first thing that you already know about apoptosis? What do you already know about it? Programmed, non-programmed? Programmed. Which proteins play a role in apoptosis? Caspases. It is programmed, caspase dependent. It is programmed, caspase dependent cell death. Apoptosis. Which proteins play a role? Caspases. Programmed, caspase dependent cell death. Next point. If you just know that apoptosis is not associated with inflammation is not seen. Apoptosis, it is not associated with inflammation. You will know everything about it. How? So, leakage of cellular contents, I can safely say leakage of cellular contents is seen or not seen? Not seen. Leakage of cellular contents is not seen. Obviously, when inflammation is not occurring, so leakage of cellular contents is not seen. And plasma membrane integrity and plasma membrane integrity is maintained or lost? Plasma membrane integrity is maintained. Which all the 3 points are the same. Apoptosis, it is not associated with inflammation. So, leakage of cellular contents is not seen. Plasma membrane integrity is maintained. Next, put a star. Apoptosis, it is not associated with cellular swelling. Recent NEET PG MBBS segment PYQ. Apoptosis does not show cellular swelling. Apoptosis, is it physiological or pathological? Physiological apoptosis is seen during embryogenesis. So apoptosis, it is both physiological. That is, during embryogenesis, many structures form and involute. So it is physiological. It is programmed cell death, physiological as well as pathological. It is both physiological and pathological. Like is seen in cases of hepatitis. Apoptosis of hepatocytes occur, that is pathological. We'll see that. So these are the features of apoptosis. Bottom line was, for those of you who have just joined back, which bottom line was apoptosis. It is programmed. Which proteins play a role in apoptosis? Caspases. Programmed, caspase dependent cell death. It is not associated with inflammation. So leakage of cellular contents is not seen. Plasma membrane integrity is maintained. It is not associated with cellular swelling. It is both physiological and pathological. Versus necrosis, which is only pathological. Only pathological. It is associated with inflammation. Inflammation is seen. So leakage of cellular contents occur and plasma membrane integrity is lost. Necrosis में inflammation हो रही है. It is associated with inflammation. So leakage of cellular contents is seen and plasma membrane integrity is lost. Those of you who have just entered, but you can take a screenshot of this. I know you might not be able to write this completely because I started slightly before you. Did you mention something? Did you eat something? I mean, might be as small as a biscuit or some namkeen or something. Yeah, nahi, abhi to we are totally energetic. Very curious, very curious. For how many of you this is your first class? That is, you are starting your MDS dental preparation with pathology. This is right now Feb going on. We are comfortable with respect to time period. Next paper is 1 year away. So absolutely do not worry, do not think that some students started slightly earlier so they are ahead of you or something. Does not matter. Does not matter. We have time. We have lots of time. So this starts us with our first pattern of irreversible cell injury, necrosis. Acha, isme bas when I say we have lots of time, what I actually mean is keep on studying throughout the year in a cool, calm manner. Do not get too hyper excited. Do not get too worried. Worst case scenario is कि initially you study a lot. This is one of the most common mistakes. Shani, unfortunately, I'm still single, yaar, Pragya. Okay, so I wish I find a nice ma'am. But coming back, uh, keep on studying in a cool, calm manner. When you sit for studying, when you sit back, your mind should be extremely calm and composed. For whatever reason, if you have fought with somebody, your HOD or department people said something, your girlfriend said something, boyfriend said something, nothing doing. When you are studying, keep those things on the side and be focused. And be calm. That is all I want to say. One of the worst mistakes that sometimes that students do is they are extremely energetic in the first 2-3 months. They study a lot, they have stopped going out, they are just into studies, and then they burn out. So they lose the next 3-4 months, as a result of which in the end the total output reduces. I'll any day prefer you studying 2 to 3 hours consistently every day as compared to 5-6 hours on few days and not studying for the rest 3-4 days. So consistency is the key to success. Absolutely no doubt. Next, so let us start with our first pattern of irreversible cell injury, that is necrosis. Let us start with necrosis. Starting with patterns of necrosis. First point. Which was the most common cause of cell injury? Ischemia. So the first pattern of necrosis, for those of you who have just joined in, let me quickly give you a recap of this slide. But your bottom line थी कि apoptosis is not associated with inflammation. So leakage of cellular contents is not seen, plasma membrane integrity is maintained. Basically apoptosis में inflammation नहीं होता, versus necrosis shows inflammation. Apoptosis is programmed. Which proteins play a role in apoptosis? Caspases. It was programmed caspase dependent cell death, not associated with cellular swelling. Recent NEET PG MBBS segment PYQ, and is both physiological and pathological. So let us start with patterns of necrosis. The first pattern of necrosis is coagulative necrosis, which is associated with ischemia of all the organs of the body. Any organ where there is reduced blood supply, there is ischemia, it is associated with coagulative necrosis. It is the most common pattern of necrosis because most common cause of cell injury was ischemia. It is the most common pattern of necrosis. Except, put a line on the side, except ischemia of CNS, except ischemia of the brain. Ischemia of any organ of the body is coagulative necrosis, except brain, which is associated with liquefactive necrosis. Except brain, which is liquefactive. Next point. Leave one line below this. I'll come back to this line just in 2 minutes. Next, there is a special subtype of coagulative necrosis called as Zenker's degeneration. This is a type of coagulative necrosis only. We are studying under coagulative. There is a special subtype of coagulative necrosis called as Zenker's degeneration, which is associated with typhoid infections, and it causes necrosis of skeletal muscle of the abdomen. कहाँ का necrosis करता है? Skeletal muscle का. Skeletal muscle of abdomen followed by cardiac muscle. Causes necrosis of skeletal muscle of the abdomen followed by cardiac muscle. Which is the skeletal muscle of the abdomen? Rajdeep Bache, you said apoptosis is both physiological. Could you explain physiological? Physiological, those Rajdeep during embryogenesis. Rajdeep, I am taking your query. Physiological apoptosis. For the others, his query is apoptosis. What do I mean by the fact it is physiological? During embryogenesis, remember notochord, thyroglossal duct. They are undergoing programmed cell death. That is physiological. Next point. So coming back. Most common pattern of necrosis is coagulative necrosis. Special subtype is Zenker's degeneration associated with typhoid. Which is the skeletal muscle of the abdomen? That is rectus abdominis. That is rectus abdominis and diaphragm. Rectus abdominis and diaphragm. This is the first pattern of necrosis, coagulative necrosis. Next, the next pattern of necrosis is liquefactive necrosis. First is coagulative, next is liquefactive necrosis. Liquefactive necrosis, this is associated with bacterial or fungal infections. Liquefactive necrosis, it is associated with bacterial or fungal infections. There was a bacterial fungal infection leading to pus formation. That is liquefactive necrosis. And it is also seen in ischemia of CNS. Remember, ischemia of all the organs of the body is coagulative, except brain, liquefactive. You know that. Next point. In liquefactive necrosis, cellular architecture is maintained or lost. There is pus formation now. So I can safely say cellular architecture is lost. Pus is forming. It is leading to formation of liquid viscous mass. Pus is forming. Cellular architecture is lost. Versus coagulative necrosis. Remember we had left one line here. Here cellular architecture. Here cellular architecture is maintained, in turn giving it the classical, think of it yourself, the cell boundaries are intact. Inside it there is necrosis, but the boundary of the cell is intact, in turn giving it the classical tombstone appearance of the cells. Giving it tombstone appearance. I'm sure all of you are comfortable with tombstone. Tombstone is कि वो पत्थर होता है with dead body inside it. That is tombstone. Tombstone appearance of the cells. That is coagulative. Cellular architecture is maintained. Versus liquefactive necrosis, where there is pus formation, cellular architecture is lost. Next, the next pattern of necrosis is caseous necrosis. Next is caseous necrosis, which is associated with formation of cheesy white material in the lungs. Associated with formation of cheesy white material in lungs. I'm sure all of you know this. Which is the first disease that comes to your mind when we talk of caseous necrosis? Caseous necrosis with granulomas or caseating granulomas, or caseous necrosis associated with TB. I'm sure you know this. What you have to remember is, other than TB, it is also associated with fungal infections. That is histoplasmosis. other than TB. Other than TB, it is also associated with fungal infections, that is histoplasmosis, caseous necrosis. Next, the next pattern of necrosis. I'll show you all these images. Let's just have a look at the theory part and we'll have a look at all the images. PG agreed those TB. Next is fat necrosis. Next pattern of necrosis is fat necrosis. Fat necrosis, this is associated with pancreatitis. Fat necrosis, it is associated with pancreatitis. Which is the most common cause of pancreatitis? Chronic alcoholism. Chronic alcoholism. Next, senin, fat necrosis. It is senin wherever fat will be present. That is senin, abdomen, thighs, buttocks. Senin, abdomen, thighs, buttocks, breast and mesentery. Breast and mesentery. Very obvious, very, very obvious. Wherever fat was present in the body, abdomen, thighs, buttocks, breast and mesentery. I need not tell you these are the sites of fat. Fat necrosis will be seen there. It is also associated with calcifications. It has calcifications due to saponification of fat. Due to saponification of fat. That is fat necrosis. Fat necrosis. Asha, tell me this also. Guys especially. Fat necrosis of the breast will be more common in young female, old female. देखो female तो is obvious ना. It will be more common in young female या old female. Answer, I'm waiting for your answer on this. Who has more fatty tissue in breast? Old female. Old female. Which is, that is why in an old female the breast is softer and it is sagging in nature. Young female the breast is firm. Older female it is softer, it has more fatty tissue. More common in old female. So somebody can ask you, what is the investigation of choice for fat necrosis breast? Though it's more of a surgery question. Older female is coming to you with a breast lump. It can be cancer also, it can be fat necrosis also. Investigation of choice, FNAC, fine needle aspiration cytology, FNAC. As a pathologist, I just need to see few cells to know whether it is fat necrosis or cancer. Versus screening test of choice. Screening test of choice in an old female is, you know this, bache. Answer. After the break, we are supposed to be more energetic now. I know it was a very small 3-4 minute break, but still. Screening test of choice. Screening test of choice is mammography. Suppose a female comes to my OPD. There is no breast lump. There is nothing. She is just saying, Dr. Saab, just check whether there is chance of getting cancer or not. There is no family history present. So screening test of choice, mammography. If she has a breast lump, investigation of choice, FNAC. So we cannot interchange the answers. Fat necrosis. Fat necrosis. Next. The next pattern of necrosis is gangrene. Next is gangrene. Gangrene, it is a non-specific clinical pattern. It is a non-specific clinical pattern. The doctor went to the ward and saw that a part has undergone necrosis. That is, he says it as gangrene. Point is, gangrene, it is of two types. That is dry gangrene versus wet gangrene. Gangrene, which it is of two types, dry gangrene versus wet gangrene. He just saw if there is pus formation or not. If pus is there, that is, it is wet. So wet gangrene is a type of liquefactive necrosis. But if there is no pus, dry gangrene, it is a type of coagulative necrosis, gangrene. So again, you tell me, diabetic foot is dry gangrene or wet gangrene? Diabetic foot. In diabetes, there is complete occlusion of the blood vessels. So the distal part of the foot, it can be the distal digits, distal toes, or even the complete foot, it has undergone necrosis. But in a patient of diabetes, the patient is at an increased risk of infections leading to pus formation. So diabetic foot is wet gangrene. Pratik nahi bache. The patient is at an increased risk of infections leading to pus formation. It is a case of wet gangrene, diabetic foot. And lastly, the last pattern of necrosis, last and the most important pattern of necrosis being fibrinoid necrosis. Rajdeep, थोड़ा सा पीछे सेशन देख रहे हो. Old female was a slightly older answer, दोस्त. I know sometimes there's lag also. So this gets us to the last but the most important pattern, fibrinoid necrosis. You need to know this. Fibrinoid necrosis, it is seen in aggressive conditions. That is, it will be a feature of benign or malignant hypertension. Fibrinoid necrosis, it is a feature of malignant hypertension. SLE, systemic lupus erythematosus. SLE, we will be doing this in detail. Systemic lupus erythematosus, that is SLE. SLE, we will study it in immunity, that is a female with butterfly-like rash, malar rash, discoid rash, SLE. When SLE affects the kidney, it is called lupus nephritis. When SLE affects the heart, it is called LSE, Libman-Sack endocarditis. I'm writing it this way here because examiner can give you all of the following are associated with fibrinoid necrosis except, instead of writing SLE, he can say LSE also, Libman-Sack endocarditis also. So both are associated with fibrinoid necrosis. Next, other diseases with fibrinoid necrosis are graft rejection. Again, we will study it in the chapter immunity. Graft rejection, but it is of three types: hyperacute, acute, chronic. Which is the most aggressive type of graft rejection? Hyperacute type. So fibrinoid necrosis is seen in graft rejection, hyperacute type. Next, vasculitis. Which vasculitis is associated with fibrinoid necrosis? PAN, that is polyarteritis nodosa. PAN, and RHD, rheumatic heart disease. These are the patterns of necrosis, and these are the diseases associated with fibrinoid necrosis. You have to know this list. There is no way you cannot know it if you just remember that it is seen in more aggressive conditions: malignant hypertension, SLE, graft rejection, hyperacute type. Which vasculitis? PAN, polyarteritis nodosa, PAN, and RHD. You will know everything about it. Actually, tell me one more thing. PAN, polyarteritis nodosa, it has two phases: acute phase and chronic phase. Which phase of PAN will be associated with fibrinoid necrosis? Acute or chronic? Which is more aggressive in nature? PAN, acute phase. So fibrinoid necrosis will be seen in aggressive conditions. Next, so fatafat say, keep on telling me the answers. Let us start with organs. Which organ is it? What do you think? Which organ is it? I want all of you to chip in and tell me the answers. Samiksha, perfect dear, acute phase. Bang on right. Next, tell me the organ associated. Which is the organ? It can be kidney as well as spleen. Where is the problem? It is showing the presence of a well-defined wedge-shaped infarct. Meaning, most probably there was a blood vessel at the apex of the infarct which underwent thrombosis. So whichever area was being supplied by this blood vessel has undergone necrosis. So what is the pattern of necrosis? Coagulative necrosis. This is This is an example of coagulative necrosis. Next, answer. This is a spotter. Agreed. Agreed, it can be spleen as well as kidney. Agreed. Varshini, Pragya, Smish. Agreed, bache. Diagnosis. This is of course brain. This is brain. Showing liquefactive necrosis. Brain में तो होता ही liquefactive है. Brain, it is associated with liquefactive necrosis. Next, this is a spotter. I want everybody to chip in. Organ, lungs, organ, lungs. This looks like a lung, of course, I need not say that. Showing the presence of cheesy white material. Caseous necrosis. Caseous necrosis. Nothing to write. Caseous necrosis. First class. Next, organ. I'm able to make out that this is a nicely well spread, lot of fatty tissue is there. That is, this is mesentery. This is mesentery, which is also associated with presence of calcifications. All these nodules are the calcifications. That is, it is a case of fat necrosis. It is a case of fat necrosis. And lastly and most importantly, answer. What do we see here? It's a blood vessel. How do I know that? It's a luminal structure with presence of RBCs in the lumen, showing disintegration of vessel wall. The vessel wall is broken. Disintegration of vessel wall with fibrin-like material. That is fibrinoid necrosis. Disintegration of vessel wall with fibrin-like material. This is what fibrin looks like. Fibrinoid necrosis. So these are the patterns of necrosis. Let's have a quick recap. Just let's see the images once again and we will, I guess, never forget them. Coagulative, liquefactive, caseous necrosis, fat necrosis, and fibrinoid necrosis. As such, you know the disease is associated with fibrinoid necrosis. You know that. Perfect. So this takes care of our first pattern of irreversible cell injury, necrosis. And before we start with our next pattern of irreversible cell injury, that is apoptosis. Before we start with this, let's have a well-deserved 10-minute break at this point. Munch on something, because around 9:30 I know you will be saying ki sir, let's have a dinner break or something, but I want to finish. Of course, we'll be finishing this chapter and starting with inflammation. So instead of 10 minutes, let's have a 12 to 13 minute break. It's exactly 8 o'clock by my watch. We start at 8:13, 8:14 with our next pattern of irreversible cell injury, that is apoptosis. Done, bache. Done. So see you in 12-13 minutes. But one thing is certain, it was our first interaction with majority of you, and I loved the interaction part with you all. No doubt about it. Keep on speaking the answers like this, keep on typing like this, and our whole path as well as micro will be set. See you in 12-13 minutes. Done, bache.